Welcome back. This is part two of the endocrine system, where we get to actually add to our list of the hormones that we want to know about now and hear about now, that are in addition to the 10 major endocrine organs and what they do. So there are a few more we're going to add to the list. And then in this part, we will also talk about disorders. So that's mostly what will be covered in this particular lecture. Now that you've had time to really study, review, and learn well the 10 major endocrine glands and all of the hormones that they release and how those hormones act when they get to their target sites, we're going to add a little bit more to that. And now when we talk about the disorders, hopefully some of this pathology associated with this will make sense to you. Okay, so let's continue on with our discovery, if you will, of the endocrine system. And as I said, lots being discovered all the time now with hormones, even hormones that we've known about for a really long time. So some of the other organs of endocrine function, and I had mentioned to you that actually every cell in the body, except for red blood cells, is an endocrine cell. They all produce hormones. They all produce molecules that can signal a response within the cell, or within a neighboring cell, or within a very far-reaching cell. So hormones are molecules that signal responses in cells. So we do understand that as we move forward through anatomy and physiology too, and we start looking at the blood, and then we'll look at the heart and vessels, moving on to the lymphatic system, respiratory, digestive, urinary systems, reproductive, we know we're going to be adding hormones to our list. So it's very important that you get these now, because the list will be expanding. Okay, so what I'd like you to know now, the ones that you will be responsible for now, and remember, it's only what I talk about. So a savvy student would be really listening to that, because if I ask you questions that I have not really talked about on these lecture quizzes, then I would throw those questions out. So just to be fair to you. Now, when we look at the kidneys, let's just start with the kidneys here. When we look at these kidneys that are green, it's kind of weird, but anyway, in the cadaver, the kidneys produce calcitriol, which I had mentioned to you, that is going to be produced in response to parathyroid hormone being released. Calcitriol is going to play a role in vitamin D formation, and then that is going to help with calcium absorption. So what calcitriol does is, from the kidneys, it targets the skin, vitamin D production goes up, and increasing blood calcium levels go up. Increase in blood calcium levels. Now, the other one I want you to know right now is called erythropoietin. Erythropoietin, the abbreviation is EPO. But erythropoietin is a hormone that will target, from the kidneys, will target red bone marrow, so that the stem cells, the early cells found in the red bone marrow, will mature into erythrocytes. The prefix erythro means red. So erythropoietin is the hormone that is from the kidneys that target the red bone marrow stem cells to become erythrocytes. Erythrocyte is a red cell, red blood cell. That causes oxygen levels to go up. Red blood cells carry around oxygen for us, so the function is to increase red blood cell production, which increases oxygen absorption. Thank you, erythropoietin. Thank you, kidneys. The other, this is not really a hormone, it's a pre-molecule to a hormone, but important to maybe get, is called renin. Renin is a precursor molecule to something called angiotensin. Angiotensin. To get to angiotensin, though, it requires pre-molecules from both the liver and the lungs, and the kidneys. Renin from the kidneys, precursors from the liver and the lungs to get to angiotensin. And what I want you to know about angiotensin is that it is the most powerful vasoconstrictor. It constricts our vessels in the body. So angiotensin constricts blood vessels, which causes the pressure inside the blood vessels to increase. So here is another angiotensin, another hormone that actually increases blood pressure. We have ADH, we have aldosterone that we learned about, and here's another that increases blood pressure. I talked to you about how deadly medical shock is. The blood pressure dropping so quickly that the heart can't keep up with that. The heart will race until it finally gets a signal to just stop. But we have all of these hormone mechanisms in place to help to raise blood pressure when it's getting too low. You can get too low for a lot of different reasons. You could be bleeding out. You could be having an anaphylactic response to something. You could be so severely dehydrated that the blood volume's so low. There are a lot of things that can cause medical shock, that could lead to medical shock. But we have built-in hormones that help to navigate that during those crisis times. And so these are some of those. So these three from the kidneys, make sure you have the basics of those. As I said, calcitriol is going to target the skin for vitamin D formation. Now, from the liver, I know it says erythropoietin here, but I actually would love to delete that, and I think I will. There you go. I didn't know it would let me edit it. I don't want you to think of erythropoietin from the liver. 85% of our erythropoietin comes from the kidneys. 85%. So it's the kidneys that are the major role for erythropoietin. Now, that would also suggest to you, if the kidneys are playing a major role in our red blood cell levels, one of the first signs when red blood cell levels are too low and not enough oxygen is being delivered, and by the way, when red blood cell levels get low, that's called anemia. Anemia. When someone is anemic, you really want to make sure their kidney function's okay, because it might be the first sign of kidney disease. It's the kidneys that make the hormone that make our red blood cells mature. So again, one of the things that you want to keep in mind if someone is anemic, you want to make sure they're not bleeding out somewhere and they're losing blood that way. Or they may just be iron deficient or whatever. We'll talk more about what can cause anemias. But one cause is kidney disease. That's one cause. Anemia is not a diagnosis. It's an umbrella term, and there are a lot of causes diagnosis. You have to figure out which one is causing it. Okay. Now, as I said, the liver produces a precursor molecule that helps to get to angiotensin. So do the lungs. So between renin, angiotensin 2, and then finally the lungs contribute a molecule that gets us to this angiotensin. Powerful vasoconstrictor, raises blood pressure. I am going to want you to also know, and it's so weird that this is, I am going to also want you to know about one from the liver called, I don't care about those other two, but I want you to know about one called thrombopoietin. Did I spell that wrong? Thrombopoietin. Thrombopoietin is a hormone from the liver that targets the bone marrow stem cells to become thrombocytes. Just like erythropoietin from the kidneys targeted stem cells to become erythrocytes, if thrombopoietin gets to those stem cells first, they'll become thrombocytes. What you all call thrombocytes, the word you use, are platelets. Platelets. Platelets are found in the bloodstream that help with blood clotting. People who have a deficiency of platelets have problems with their blood clotting. They're easily bruised. They can actually, have a risk of bleeding out. So one of the things to think about with liver disease, one of the first signs of liver disease is that there's a platelet problem. There's not enough platelets being produced, and there's bleeding issues, problems. And that makes perfect sense because we know the liver is actually contributing. It is a major player in blood clotting. So that's why blood clotting issues are often because of liver disease. And then you'd have to figure out what the liver disease is from. Is it from abuse of toxins, like poisons, like alcohol and other things that can attack the liver? Is it because of viruses that have attacked the liver? There are a lot of reasons that could be. But it could be, you really got to watch the liver for that. The heart, I am going to want you to know about one. It's called atrial natriuretic peptide. Sometimes it's ANF, so atrial natriuretic factor. If you ever hear the word factor, it's usually referring to some type of hormone or signaling molecule. So ANF, atrial natriuretic factor from the heart, is going to target the kidneys, and it's going to cause sodium to be excreted. When sodium is excreted, water follows it, so urine output increases, and as urine output increases, blood volume's going down. So as blood volume is going down, blood pressure is going down. Let me say that again. ANF, or ANP, atrial natriuretic peptide or factor. This is a hormone from the heart that gets sent to the kidneys. The kidneys will cause sodium to be excreted. Water will follow it. Urine output increases. Blood volume goes down. And as blood volume goes down, blood pressure goes down. So we have heard of several hormones that raise blood pressure, and here is one that decreases it. So this is actually an antagonistic hormone to aldosterone and angiotensin and ADH. It's antagonistic because it does the opposite. Just like parathyroid hormone did the opposite of calcitonin, they were antagonistic. It makes sense because when we are mostly in negative feedback, you're going to have something that decreases a level and then another hormone that increases it. They're called antagonists. If they're all doing the same thing, they're called synergistic, and they're helping with the process. So many medications that you hear about, when you hear about them and their synthetic versions of these hormones, you'll know exactly what's going to happen in the patient when you're given these. Okay? All right. So from the kidneys, we knew about calcitriol, erythropoietin, and renin. From the liver, we just did two. We know it's a precursor to angiotensin along with renin, but we know what angiotensin does, and we also know about thrombopoietin. From the heart, we learned about ANF, atrial natriuretic factor. Let's see if there's any other ones. When you hear about enteric hormones, it means hormones from the GI tract that's going to help with motility. 30 feet is a long way to move something after you voluntarily swallowed it. But once you voluntarily swallowed something, you don't really have to think about it moving for 30 feet. But these hormones are causing movement to happen. They're also causing enteric hormones not only contribute to the helpful movement along, but absorption, secretion of other hormones that help with breaking down nutrients and absorbing nutrients. So enteric hormones are related to the GI tract. What other things do I want you to know? We also know that the placenta, once it's formed, we'll talk more about that, but once this is formed, a little bit later during the embryonic development, it takes over as far as supplying the hormones that are necessary to sustain a pregnancy. But we'll talk about that as when we get to the reproductive system. Fat tissue, adipose tissue, we learned about. It does secrete leptin. Leptin is a hormone that we know slows appetite. So anyway, these are just some of the additional hormones you want to have on your list now as separate. As far as the chemistry and the structural components of these hormones, this is all FYI. I'm never going to test you on these. Some of them are fat-based, like the steroids. Some of them are protein-based, like insulin. So, or ANP, which is a peptide bond, a factor. So some of them are protein-based and some are fat. I'm never going to ask you which is which, but just to understand. So when we think about how cells function once a hormone has stimulated them, this again is FYI. I'm not going to test you on this, but I hope it's intuitive. If you have a cell that's a target cell, here's a cell that's a target cell where my mouse is, and a hormone's out there acting with a receptor, because that's why it's a target cell. It has a receptor that receives the hormone. That cell first will put more receptors to the membrane so that the response will sort of uptick, and now the cell is really functioning. This is called upregulation. Now, and sensitivity is increased. But there will then be a signal for the cell to start down regulation. And this is controlling when the hormone is dissipating and or, going down, or the cell has another signal. Then the cell starts to slow down its response, down regulation. Now, this is important that this functions the way that it should. When we're about to talk about hormone disorders, and you need to really hear this part. A lot of times in endocrinology, when we're thinking about hormone disorders, it might have nothing to do with how much hormones being produced. Plenty of hormones being produced. But it's that the cells, the target cells, are not putting their protein receptors to receive it. So upregulation never happens. That would be a problem. So I really need you thinking about, before we talk about these disorders, this idea that when there is an endocrine problem, there could be so many different reasons for the problem. It might be the organ that's supposed to be secreting the hormone. It might be that. It might be that the hormone is not being secreted at a high enough level. It might be, though, that the cells that are the target cells have lost their sensitivity, which means that they never get this up response. And they've lost the sensitivity to it. So, and it could be that the body is not sending signals to the hypothalamus, talking to the pituitary, talking to the next ones. There's lots of levels of places where the error could be happening. Please keep in mind that we do need to figure out as much as we can figure out about what's going on, because that will dictate the treatment. And so that's why it's so important that you have a good understanding of these now, because then you would understand why a patient is being treated with what they're being treated with. Remember, all disease is at a molecular and cellular level. All disease. Okay, these are just one group. But all disease. Again, I talked about synergistic and antagonistic, but I do want to talk to you too about the idea about your body, being in a state of health, being in a state of balance, but then something happens, and that's us in the natural world, right? We either encounter a virus, or we have a bacterium or protozoa or whatever might be affecting us, or we have an accident, or just whatever might have happened that caused stress. So stress can be anything that threatens someone's homeostasis. It can be injury, surgery, infection, and as you can see, a lot of these things, even emotional. So we get that. There are 3 stages that occur when we're thinking about how the body responds naturally. The first is called alarm reaction, where the body is alerted. The nervous system's the nervous system's picking up on that. Then there's the stage of resistance, and then hopefully it breaks right here, because if not, you're going into stage of exhaustion, which could then, depending on how bad any of this is, lead to death. So the first stage is that fight or flight. The epinephrine, norepinephrine, the adrenal medulla, giving us that fight or flight response. Glycogen's going to be broken down because we get glucose, we get energy. We can fight. We can fight or we can run. We can try to repair things because we're needing repair because we probably didn't win every fight. Okay. We increase aldosterone and angiotensin, so blood pressure goes up. Remember, blood pressure going up means blood's running faster to everything. That's all. These are all things that are part of the process. Then there is a stage of resistance that actually occurs. So after some hours are done, the glycogen's gone. But the brain still needs glucose. There are two types of cells in your body that can only run on carbohydrate energy. They are the nervous system, your brain, and your red blood cells delivering oxygen. So we really have to have sort of a constant supply, or those two systems are going to be compromised. So let's think about stage of resistance. Already the nervous system is becoming a little bit more compromised. The stage is dominated by cortisol, which is a steroid that's going to help with tissue repair. So it has the good function of helping with tissue repair, making sure that we have enough glucose to be able to heal and to help with tissue repair. But what can happen is that this can also have some bad side effects as well. It can throw off electrolyte balance. It can actually start to hinder that. So if we don't break the cycle here, a lot of times our bodies break the cycle. So we start to heal, we start to get better, and things get or whatever. If we don't do this, if we don't stop it here, we end up getting into this stage of exhaustion. And that's usually after a prolonged period of time. And now fat reserves are gone. You're actually breaking down proteins. You should never have to break down proteins for fats, for energy, or for use of energy. So proteins are breaking down, muscles are wasting. The best thing to kind of explain this to you, because I think we've all seen, is late stage cancer. People in late stage cancer and or emphysema and or kidney failure situations. So electrolyte balance is completely off. So one of the most dangerous electrolyte imbalances is potassium. So now we're leading where our pH is off. So our pH is off, and we're also having cardiac arrhythmias. So cardiac arrhythmias decreased nervous system functions, and so it can be overwhelming. So those are kind of the three stages that happen in any kind of insult. But hopefully, you sort of stop it right here, or this can actually happen if it's prolonged. Now, what I'd like to do is to talk about some disorders. Okay, a lot of these other slides are actually just sort of chemistry related that you won't need to know about. You do have, I'm pretty sure you have a deeper insight in your chapter that you will want to read before this test that's on the endocrine system. But anyway, it talks about steroids versus non-steroidal drugs and just how they can actually help and what they're actually doing, what their function's actually doing. So I would want you to read through that deeper insight before the test on this, but that is not going to be on this lecture quiz. Let's look at some disorders. I've told you that when you think about disorders, it could be because of a hyposecretion, not enough, or it could be because of a hypersecretion, too much. An example of a hyposecretion is diabetes insipidus. This, you need to understand, has nothing to do with the pancreas or glucose. The word diabetes is a word that simply means that you're producing a lot of urine. That's what that word means. It doesn't mean anything to do with anything else. It's just producing a lot of urine. But in this case, in diabetes insipidus, it actually has nothing to do with glucose. It has everything to do with ADH. So ADH is actually that antidiuretic hormone that we say gets produced on a regular basis that helps to preserve water retention and keep us hydrated. An example of for an adult, a normal urine output is about 1.5 to 2 liters of urine a day. That's a normal adult that's well hydrated, right? If a person, that same normal adult, all of a sudden stops secreting ADH, they can make as many as 10 liters of urine a day. 10, from 1.5 to 2 to 10. So you can imagine that that's not compatible with life. That would be losing too much water, and it would be dangerous. So if there has been something that happened that destroys that part that of the tissues that respond to the release of ADH, and ADH is not being released now, diabetes insipidus is the disease. So there is a lot, poly means a lot, right, of urine output. Polyuria just means a huge urine output. The good thing, you can take nasal sprays and replace ADH, and so daily nasal spray replacement of ADH is required for life. If somebody has diabetes insipidus, it's not a hard treatment, but it has to happen. So, anyway, this is a hyposecretion of ADH is called diabetes insipidus. Make sure you would understand why there would be chronic polyuria. Hopefully you do understand that, because we had talked about it in type 1. Hypersecretions are when there's too much of a hormone being produced. And again, the most common reason for that is tumors. And on occasion, it's because of autoimmune diseases. The most common is tumors. So a treatment is usually to remove the tumor. Okay? But anyway, here's some examples of hypersecretions. Pheochromocytoma. Anything that ends in OMA is a tumor, isn't it? So pheochromocytoma is actually a tumor of the adrenal medulla. And we remember that the adrenal medulla, that middle part of the adrenal gland, secreted our fight or flight hormones that stimulated the sympathetic nervous system, epinephrine, norepinephrine. And you can't live like that. You can't live in a constant state of fight or flight response. So what they typically do is remove the tumor, and that usually takes care of it. This is an emergency situation if somebody's in this. If they're staying in this, they're at risk for a heart attack or stroke. So it's very important that this be addressed and the tumor removed from the adrenal medulla. There's also another example I could give you, and that's the toxic order Graves' disease that I talked about. In this case, there are autoantibodies, self-antibodies that were generated by your own immune system that should never been generated. So these antibodies attack really the thyroid by mimicking TSH. So the thyroid's minding its own business. And it's thinking TSH is telling it to secrete T3 and T4 because that's what it thinks that is happening. But it's really not TSH. It's an autoantibody that is so similar in structure to TSH that it's mimicking it. So again, this can lead to a toxic goiter known as Graves' disease, where all metabolism's too high, caloric use is too high. The person might be losing weight. It's affecting their skin, their hair, their thought processes. They may not be able to sleep. They can't keep enough weight on. They're hot when no one else is hot. Just their metabolism is too high. So that is Graves' disease. Some other disorders, pituitary disorders, let's look at. There's a hypersecretion of growth hormone. Now listen carefully to what I'm going to tell you. If that happens in childhood or adolescence before you've reached your full height potential, if the hypersecretion happens then it can lead to gigantism, or giantism it's also called. So because you continue to grow, right? And there is an optimal range of body size that is perfect for the body's organ systems. Cardiovascular systems work at best. Homeostasis range is not too tall, whatever you want to be in the right range. Your joints, your musculature, all that stuff is really at optimal levels of size. So it can really adversely affect your health if you are way out of that range. So too much growth hormone. Now, if the hypersecretion happens in adults, so you can't get any taller because the growth plates, those epiphyseal plates and bones have closed off, so you're not going to get any taller. But what it can do is start to affect the irregular bones, like the bones in the hands, the feet, the face, the brow, the jawline. So what you see is this young girl who developed absolutely normally to full potential at age 16. Women reach their full growth potential much earlier than males do. And again, that's related to estrogen production at puberty for women. But what happened to this young woman is that as she grew, she ended up getting a hypersecretion of growth hormone. And you can see how it affected the jawline, the brows, her hands, and whatnot. So this is called acromegaly. Acromegaly. And hypersecretion of growth hormone that the onset is in adulthood. Gigantism is hypersecretion in children of growth hormone. Now, a hyposecretion in children would lead to dwarfism, pituitary dwarfism. This is the type of dwarfism that is, and I don't know what the actual height for an adult would have to be before they're considered to be a dwarf, a medical term for that. I don't know what that magic number is, just like I don't know exactly what the magic number is to be considered a giant. But anyway, you could look that up, and I'm sure it would just depend on what region you're in, actually. So there would be some gray zones in there. But pituitary dwarfism is suggestive, of that there was a lack of growth hormone during the developmental period of that individual. So anyway, and we do, by the way, we don't just make growth hormone using bacteria to make growth hormone. We use microorganisms, bacteria, and yeast to make all kinds of hormones. Insulin, growth hormone, multiple hormones. We have genetically engineered these microorganisms to produce these important medicines that have been used for decades. So, and they can do it inexpensively and safely, rather than having to get them from human donation, which is very much at risk for other humans spreading diseases. But these microorganisms are completely safe, it's cheap, and they are the human variation of the hormone, because we actually insert the human recipe for those particular hormones. So let's look at thyroid and parathyroid disorders. So when we look at thyroid disorders, we know that that's the gland for metabolism. When we think of the word congenital means at birth. So congenital hypothyroidism is a decrease in those thyroid hormones T3 and T4. Thyroid hormones T3 and T4, triiodothyronine and thyroxine. So you can just replace that, but it's important that the diagnosis happens early, because if it does not happen early, it can lead to permanent damage. And then by the time the diagnosis has happened, you can't get you can't correct some of the things that are going to happen. Myxedema is actually a decreased thyroid, and it's in adult thyroid hypothyroidism. I do want you all to know that one of the most common autoimmune diseases for that is actually due to something called Hashimoto's thyroiditis. This is autoimmune, and it's so common. It's like 1 in 8 women, just like a lot of autoimmune diseases are more in women. Not exclusively, there are a lot of men with autoimmune diseases too, but more in women. And it usually happens around the age of 20 to 40. The onset starts, like a lot of these autoimmune. And the onset can be really slow. So women think, oh, I'm just gaining weight. Oh, I'm just tired now because my life is getting overwhelming. Oh, I'm losing my hair, or my hair is whatever. My skin is, I have rashes that I'll never have. These types of things. Tired, cold when no one else is cold. Low metabolism due to a decrease in thyroid hormone. That should all make sense. Again, treating with supplementing a synthetic version of the hormones. It's called Synthroid or levothyroxine. So you just take it daily. Goiter, I had told you, is an enlarged thyroid gland. Just because you have a goiter doesn't mean you have a diagnosis yet. You've got to figure out why. It could be an endemic goiter, which is due to a lack of iodine. Make sure you know that. It could be a toxic goiter, which is going to be that autoimmune disease we called Graves, right? Or it could be this myxedema. This can also cause a hyposecretion related goiter. So we see this picture of a person with the thyroid gland enlarged, and you have to ask yourself, why did they wait this long? This was due to an endemic goiter, and bless her heart here. So obviously an easy treatment for this is giving iodine, replacing iodine in the diet. We rarely see this kind of thing anymore because almost no matter where even if you live on a farm that's sustainable and you're eating all your own vegetables and your own fruits and your own meat that you're raising on your farm, most soils have iodine. So the foods take up, and the animals have taken up the food, the plants that took up the iodine, and then you eat it. So it's rare to see this now because actually most people are going to buy something, and almost anything that's bought or purchased has had iodine replaced in, has iodine in it. So all the salts that you buy in grocery stores have iodine that has been placed in it. So this doesn't happen as often. As far as the parathyroid glands, there's 4 little glands on the backside of the thyroid gland. Hypothyroidism is usually due because someone has removed these glands during thyroid surgery. That's awful, because if that is the case, that all of them were accidentally removed, then this is fatal, because it's going to lead to a hypocalcemia. It can lead to tetany, and this tetany, the fatal tetany, will cause suffocation. So anyway, that's hypothyroidism. Hyperthyroidism means there's too much, and this is usually due to a tumor, just like a lot of hypersecretions. There's too much calcium in the bloodstream, and then it's going to crystallize. So as the kidneys are filtering blood plasma, because that's all urine is filtered blood plasma, you're going to end up making kidney stones. So kidney stones are actually, the medical term for kidney stones are renal calculi. That's the medical term for a kidney stone. But it also is going to be pulling it from your bones. So if it's left unchecked for a while, it's going to end up affecting your skeletal health. So bones become soft, they become fragile, and even deformed if it's left to go for too long. So again, it's usually because of the tumor. So the parathyroid tumor and some parts of the gland have to be removed, but you do not want to remove all of them, right? Because you would see what would happen here. Adrenal disorders. There are quite a few adrenal disorders that we'll talk about. The first is Cushing's syndrome. So in Cushing's syndrome, there is either an excess of, there's a tumor of the adrenal cortex, which is causing an excess of these mineralocorticoids and glucocorticoids, or there is an increase of ACTH from the pituitary that is just keeping the adrenal glands active. So it can be from either one cause or the other. Too much ACTH from the pituitary, or because of a tumor of the adrenal cortex. So this is not uncommon. If it's in children, they don't give you the picture of this young boy 3 months prior, but I think in your textbook you have a picture of what this young boy looked like just a few months prior to this, and it was unrecognizable, the change. So just like this moon face appearance that you get if someone's been on prednisone too long, they get that kind of electrolyte imbalance that you see, fats depositing in areas that are very unique to this type of situation, in the shoulders and neck and in the face, and proteins breaking down. So this is something that you definitely want to to see. Now, in adults, it's very different, the sort of presentation. This is an obvious presentation in a child. In adults, it can be really slow coming on. And again, it's throwing off your glucose homeostasis, so now you're hyperglycemic, which means too much glucose in the bloodstream. You have hypertension because of the electrolyte imbalances. There's edema, which is swelling in the tissues that you shouldn't have. All of these things are happening in adults, and again, this happens more in women than in men, but they can get what's called a buffalo hump and a fat deposition in a very, sort of a significant place in the face. So that buffalo hump, that mound of fat that's between the shoulder blades, just above the shoulder scapular region, can be indicative of that. Okay. There's also something called AGS, adrenogenital syndrome. This is going to be something that we see with, when we see this in little children and newborns, it's going to cause the little girls to look like they have masculinized genitalia. Do I not really have a picture of that? You do in your textbook. So you have a picture of this in your textbook. I could probably go to, I could Google AGS and infants and show you a couple of pictures. This long ago, you would have to wonder, I hope this is going to be the one that it's not going to show. That's not showing that. So anyway, I would suggest you to go to your textbook and look at this. In these female girls at birth, their labias are suffused, and the clitoris, which is the sex organ that's analogous to a penis in a male, is so enlarged it really could theoretically be misconstrued as a penis. So there's masculinized genitalia in the female, and so that is a problem. And if it happens in women, like adult, if it doesn't start, the onset doesn't start until later in women, then what's going to happen is the larynx, just like testosterone does for males, the increased testosterone, the androgens from the adrenal glands in women will cause the larynx to enlarge, the voice will deepen. Women will even have problems with problems for women, not problems for men, but they'll start to see hair like beard growth, increasing body hair, just like testosterone does in males. So this, again, is because of a hypersecretion. It can, obviously also accompany Cushing's, but it's a hypersecretion of those androgens. Now, there's also, and it's so funny it's not mentioned here, but I'm going to add it. It's so weird it's not mentioned. I'm going to add this condition because it is, it's important. So I'm going to add it to your notes here. And I don't know why they left it off in these PowerPoints. This is called Addisons disease or syndrome. Addisons disease. Addisons disease is actually, if you think about Addisons of the adrenals, this is the opposite of Cushing's. So now there is a decrease, a hyposecretion. So now instead of having hyperglycemia, there's hypoglycemia. And instead of high blood pressure, there can be low blood pressure. Again, this disease is not that uncommon, and it's a hyposecretion, so what's going to have to happen is replacement therapy of the hormones. So Addison's disease, the opposite of Cushing's. All of these are related to the adrenal glands. We also mentioned that pheochromocytoma, that is the tumor related to the adrenal medulla that can cause that fight or flight response staying constantly, that has to be removed. That tumor has to be removed immediately. Now, diabetes mellitus, not to be confused with diabetes insipidus. Diabetes insipidus had to do with ADH, not secreting enough ADH. In diabetes mellitus, this is having to do with the pancreas. And this is having to do with blood glucose levels being out of homeostasis. Please look, the most prevalent metabolic disease in the world. Right now, the World Health Organization, along with CDC, Centers for Disease Control, we realize we're in a real crisis around the world right now, even in developing countries, with people who have obesity. And obesity is leading to type 2 diabetes mellitus, which used to be called adult onset diabetes mellitus, and it is due to poor diets, poor management of really lifestyles, and it's a killer. It really is. When we look at just in developed countries like the United States and other developed countries around the world, as much as half of the medical budgets are going into place to treat people because of their consequences of diabetes mellitus. Now, not all diabetes mellitus are created equal. There are a couple of different types, and they're very different, the different types. What I want you to know is what's common among all of them is often the symptoms, and the symptoms can be too much urine output, so excess urine output, an increased thirst because you're losing water, so your brain's getting the information that you're thirsty, so you keep drinking to try to replace your blood volume that you're losing because you're urinating too much. And then also that you're very hungry because you're not able to use glucose for fuel the way that a normal person would be using it. So you're getting these signals that you're hungry, you're dehydrating because you're urinating too much, so you're getting signals that you're thirsty. And these are common in all diabetes mellitus types. There's also hyperglycemia. There's also glycosuria. You should know those terms. Hyperglycemia, glycosuria, one word, glycosuria, means glucose in the urine. And polyuria is up there. And then there can also be ketones in the urine. What you want to know about ketones in the urine, this is a huge indicator that somebody's having trouble using glucose as energy. Because instead of using glucose as an energy, they have to turn it to fat first, and then the fats have to be broken down for energy. Fat is a great energy alternate source of fuel, but you should not be using it predominantly, and you should be using it rarely. Because when you burn fats for energy, sounds like it would be a good idea because you'd be losing weight. But when you burn fats for energy, you get a byproduct called ketone bodies. These ketone bodies are actually something then that your body's going to have to deal with. And they change the pH of your blood. It's called ketoacidosis that you go into. And then that's throwing off other systems in homeostasis. So seeing ketones in the urine means that you're burning fats for energy. If you've got high enough levels of them, you could be in what's called ketoacidosis, which can be, it disrupts multiple homeostasis systems in the body anytime the pH is out. Okay, so the different types. Let's look at the types. Type 1, which is actually, and you want to know this, called insulin-dependent diabetes mellitus, is the type that is actually autoimmune. And I don't know if it has this on here. Yeah, well, it says it makes autoantibodies. Okay, so this is the autoimmune one, where the person's immune system starts attacking the beta islet cells in the pancreas, and that insulin levels start to go down. Before we were able to get insulin as a readily available drug by using genetic engineering of microbes, this was a death sentence. A death sentence. It wasn't very long ago that anybody you know that has type 1 diabetes, that's usually, it used to be called childhood diabetes mellitus, because people are usually from the age 2 or 3 years old up until like late teens. Some people develop it even in the early 20s. So, but usually early in childhood. This was deadly, and they died from it. They died a very young death after the onset. But now we do have microorganisms through genetic engineering that can produce human insulin. And so people with type 1 can really try to regulate this. So it is very much known that there is probably a hereditary component, but then when someone gets infected with something pretty mild, actually, things that are usually fairly common, they create autoantibodies that mimic and destroy the beta islet cells. They don't really mimic, they actually just attack and destroy these cells because they made these antibodies to attack the viruses. But they look so close in structure that the beta islet cells get destroyed too. It takes a little while, like months and even a couple of years, so that's when they call someone who's type 1 diabetic in the honeymoon phase. If we could stop that process, which a lot of the treatments now are gearing toward stopping that process so the person doesn't really lose all of their ability to make insulin, that would be a good thing. But anyway, this is a devastating disease, and just it's devastating. Now, type 2 is non-insulin dependent diabetes mellitus, non-insulin dependent. This is by far and away most diabetics. And the problem is actually not so much that the person's not producing insulin. It's not because something attacked their beta islet cells, not at all. They have insulin. The problem is that the target cells are not responding. You know how I told you in upregulation, the target cells have to be able to respond by placing receptors. The target cells become so tired of so much insulin being produced that they stop doing it. They become insensitive. It used to be that we really only saw type 2 diabetes if there was a hereditary basis, the people were old, obesity was there, and certain ethnic groups were more at risk. That's not the case anymore. We have children that have such stationary, sedentary lives. They're not active. They have weight issues. Even obese. Being overweight is not the same as being obese, but they have obesity issues, children. And so now we're seeing epidemic proportions of our children being diagnosed with this type of diabetes. Now, the good news is that if people can lose weight, if they can become more active, that's easier said than done. You know, changing behavior is easier said than done. People can sometimes go off the treatment because their numbers can get back down to normal. The problem comes is that, and that's the goal, that would be the goal, to be able to do that. Lose the weight, become more active, have numbers go back down. You can go off your medicine. So that's the goal. But once a person's diagnosed with type 2 diabetes, even if they're able to do all that, which is wonderful, they still always will have that diagnosis, and their bodies will always have that propensity to have that problem. So that becomes the problem. Now, ketonuria, ketones in the urine, ketoacidosis, throwing off pH, affecting respiratory, affecting kidney function, affecting the nervous system. Increased levels of glucose in the bloodstream for sustained periods of time, and it doesn't have to be outrageously high, just even a little high, is neurotoxic, meaning that increased levels of glucose in the bloodstream for too long is actually causing neuropathies. So those neuropathies are nerve damage that is not going to be able to be fixed. And so you can see some of these problems: wound healing, lack of sensation, so you don't even know if you've injured something. Blood supply is compromised to the tissues, so then you end up having risk of amputations because of gangrene that can set in because of lack of blood supply. Sight can be lost. Kidneys fail. If you know anybody that is on kidney dialysis, full-time dialysis, to clear their blood because their kidneys have failed, the majority of them are because of mismanaged or brittle diabetes. They didn't manage it well, and so it ended up affecting the kidneys over time. That leads to hypertension. The hypertension ends up hurting the kidneys over time. So it's all together. All of these are together. So this is the pathogenesis of diabetes mellitus. This concludes our introduction of the endocrine system, and a majority of the hormones will be responsible for in AMP2, though we will be adding to our list as we go. And then also an introduction to some of the pathology from some of these organs when they are not performing as they should. I hope that you found it fascinating, and there will be a quiz just from this part 2 lecture to follow. So good luck and take care.